Welcome, everyone. Good morning, good afternoon. My name is Catherine Chu, and we will get started in a minute or so. We're just waiting for a few more people to join. I just wanted to ask everybody, if you are not speaking, if you could put yourself on mute. My name is Catherine Chu again, and I'm the director for the Center for Global Surgery in Stellenbosch University in South Africa. And we've got a wonderful satellite session planned for you this afternoon or evening or morning, depending on where you are, talking about AfreHealth CUGH partnership and specifically building global health capacity in the African region. I think it is now 5 past, so we're going to go ahead and get started. I'm just going to spend 5 minutes introducing our speakers. And they can tell you a little bit more about themselves as we go. We're going to start with Dr. Elsie Kuguli-Mawade. She's a radiologist and the president of AfreHealth. She's also the Secretary General for the Network Towards Unity for Health, a global organization with a vision to improve global health professions education. She has over 25 years experience in medical curriculum development, evaluation, and medical education research at the pre-service and postgraduate levels, and she will talk to us about AfreHealth and CUGH and the history of the partnership. Next, we will have Dr. Francis Omaswa. Dr. Omaswa is a surgeon and a global health specialist. He's the director of special projects at HS, the African Center for Global Health and Social Transformation. Previously, he was the Director General for the Health Services in the Ministry of Health in Uganda, during which time he was responsible for coordinating major reforms in the health sector, including introduction of swaps, quality assurance, and decentralization. He will be talking to us about mutual learning in global health, leveraging our strengths. After that, we will have Dean Abebe Bekele. Abebe is a thoracic surgeon and the Dean of the School of Medicine at the University of Global Health Equity in Rwanda. He is member of the Governing Council and Chairman of the Exams and Credentials Committee at the CUGH, or the College of Surgeons of East, Central, and Southern Africa, and he's the Editor-in-Chief of the East and Central Africa Journal of Surgery. He will be talking today to us about African collaborative training initiatives using CUGH as an illustrative example. Next up, we will have Dr. David Muganzi Jolly. Dr. Jolly is a highly motivated young doctor with a passion for improving healthcare quality in Africa. He holds several leadership positions, including president of the AfreHealth student community and chairperson of the patient-centered care movement in Africa, a student-led initiative that is advancing patient-centered care across the continent. Then we will have Dr. Quentin Eichbaum. He's a professor of pathology, microbiology, and immunology, and a professor of medical education and administration at Vanderbilt University in the US, where he also directs a fellowship in pathology and the pathology program in global health and the Vanderbilt Pathology Education Research Group. He's also a CUGH board member. He will be talking about a global health survey. What does global health mean in a post-colonial world? And last but not least, we will have Dr. Andrew Dykins. Dr. Dykins is an associate professor of family medicine and family and community medicine in the University of Illinois in Chicago, a core member of the UIC Center for Global Health. He's the founding director of the Capacity Strengthening Platform at CUGH, a global initiative that aims to facilitate institutional partnerships focused on strengthening healthcare training capacity by connecting locally identified human resource gaps with existing resources. I'm going to stop sharing my screen now, and I'd like to ask Dr. Elsie to kick us off with a history of the CUGH AfreHealth partnership.
Thank you very much, Catherine, for those introductions, and I'll share my screen now. Okay, thank you all for attending this satellite. I would like to thank CUGH for putting this together. And Catherine, thank you so much for all the work you've done to make it come to pass. So I'm going to give you the background to the AfreHealth CUGH working group. And since there are many of you that may not know about AfreHealth, I'll begin off with telling you about AfreHealth and how it came about and what we do. Then I'll tell you about how we formed the SCWG and what we are doing with that. So the African Forum for Research and Education in Health was established in 2016 in Nairobi. It is a pan-African network representing health professions and institutions from all over Africa and a few international members. And our aim is to sustain the outcomes of the Medical Education Partnership Initiative and the Nursing Education Partnership Initiatives, in short, MEPI and NEPI. And these were two programs that were PEPFAR grants to countries in Sub-Saharan Africa that aimed at improving health professions education in the region. And now AfreHealth is one of the largest Pan-African interprofessional and multidisciplinary organization in our region. And just to give you a bit of the MEPI aims and outcomes, they link to each other. What was done, what we wanted to sustain, and what we are sustaining now. It was about increasing the numbers and quality of healthcare workers trained in the region to address the critical shortage of healthcare workers in our region and trying to retain them where they are most needed over time, and also to support regionally relevant research. And one of our aims and outcomes was to sustain those programs, and that's why AfreHealth was formed, and also to create communities of practice like the SCWG. So those were the outcomes of MEPI, and that's where AfreHealth came from. Those were the countries that were involved in MEPI and NEPI. I just gave you that map so that when I show you the one of where AfreHealth is now, you'll see that it has expanded beyond that. And if you would like to know more about MEPI, NEPI, and how it formed AfreHealth, there's a publication in the Lancet Global Health that you can look at on Medical Education Partnership Initiative, giving birth to AfreHealth. So what does AfreHealth do? AfreHealth works to achieve excellence in health professions education, research, and service delivery. And we want to influence a new professional standard that will result in sustainable and continuous quality improvement for the African population. We serve as a leader and convener for scaling up South to South networking and collaboration across the African continent, but we also collaborate globally, as you can see at this meeting. And this all is aimed at addressing the daunting health workforce challenges, which we all know, the numbers that are limited, the skills mix. How do we make sure that it is there to, the skills mix is good to meet our needs? What about how can we retain them? How can we train them? So all those challenges that are causing problems for us in the health workforce, that is what we are addressing. And we do this through supporting innovative interprofessional education and research, as well as service delivery. So this is where AfreHealth is now. You know, those countries we have for members of AfreHealth, either as individuals or as institutions. So those in blue are the countries we have not reached, and our dream is that by the end of this year, all those countries have been reached by AfreHealth. Our activities include research. We do research and publish it. We do capacity building through various, in various ways. We do interprofessional student exchanges. We do a lot of webinars, and this came in very handy during COVID-19 because COVID was a new entity and we had to do a lot of training, and the health professionals, most of them were locked up in their homes, and to see how to do health professions education during that difficult time. So webinars are really part of what we do. And then we conduct an annual symposium. And this year it will be in Maputo, Mozambique, and I'm inviting you all to that. And we form communities of practice. Some of these date back to the NEPI days, but also new ones have come up since then. So we call them technical working groups. So about the CUGH, we came together in 2017 at the AfreHealth Symposium. It was the first AfreHealth Symposium that was held in Accra, Ghana. And there were some members from CUGH and some members from AfreHealth, and we said, how can we work together? How can we partner to work together? So that time we had a workshop, just getting to know the partners and testing the interests. And this slide is full, but don't worry about it. All I want to show is that nearly every year since then, except 2020 because of COVID, we've been having satellites either with the CUGH conference or the AfreHealth symposium. And this sometimes happens before the conference like this time or after. So we've had these in various locations, but we've also had 2 virtual ones during 2021 when both CUGH and AfreHealth held virtual conferences. And our activities include conference workshops like this one, satellites. We also have online discussions, small group discussions. We do publications. We do have technical working groups or subcommittees. And then we share board membership, like now the Vice President of AfreHealth, Professor Alfred Muteta, is a board member for the CUGH board. So this is really work in progress. We continue to build the ship as we sail, and so far so good. So we had a pre-conference in 2018 in New York, and when we were there, we carried out a short survey to see what people were interested in, to explore the areas for collaboration, and so many things came up, like health professions, education, academic health complexes. So there were varied things that people were interested in. So we distilled this further, and still there were many. People were interested in interprofessional learning, leadership development, research capacity development. And when we met again in Chicago, at a pre-conference symposium in 2019, we distilled them further and came up with 3 working groups, and those are the ones that have been functional. One on research, one on student exchanges, and another one on health professions education for health systems strengthening. And members registered for these groups. They set their terms of reference, they have a listserv, then they had tentative work plans which have evolved over time, and they keep holding meetings whenever possible. And this is an example of, this is a screenshot actually of the satellite meeting we had in 2022. Some of you may recognize yourself in that screenshot. So just to give you an example of the topics of discussion we've had, we invite prominent or experts in different fields, and they come and talk to us at the CUGH. So we've, for example, reflected on global health in a post-pandemic world with a decolonized mindset, and Jimmy Vomic, who was the dean then of Faculty of Medicine, Stellenbosch University, talked about that. We've talked about the global health work crisis by Jim Campbell. How do we address social justice and equity in Africa's fight against COVID-19, and that was spearheaded by John Nkengasonga, who is now the PEPFAR boss. So what are the SCWG outcomes? We feel that through this, we have had global North-South partnerships that are an effective way to generate rich ideas that focus on improving health systems through collaboration. We have a network of networks because we collaborate across the continents. We consider equity, diversity, and inclusiveness so that all of us actually gain from this partnership. And we represent multiple professions that can share their experiences in various domains. And we also do publications. That was one of the publications which was led by Quinton Eichbaum, whom you'll hear from today. And it shared the experience we had at a satellite meeting. We are also exploring bi-directional student elective exchange. And this was kind of halted because of COVID, but we are still exploring that because there's a lot of interest in that. So we use this African proverb, which I really love. If you want to go fast, go alone. If you want to go far, go together. So as a partnership, we want to go far and we want to go together. And our past president, Marieke de Villiers, a professor at Stellenbosch University, added on leaving no one behind. So we all want to go together, leaving no one behind. And that is about our symposium this year. We would like to welcome you for the AfreHealth Symposium. It will take place the first week of August in Maputo, Mozambique. And so many people have already registered for it. So please register through our website, and we hope to welcome you there. And we'll have a SCWG satellite at that meeting as well. So we work towards a responsive health workforce, providing relevant, high-quality, evidence-based healthcare in Africa. That is very, very important for us. So thank you very much. And the question I would like to leave you with is, how can we leverage this partnership to improve global health education? And so the different people who are here, if you have some answers to that, would like to incorporate whatever your thoughts are in this work. And when we come to discussion, maybe we shall have some points from you. Thank you very much. Over to you, Catherine.
Thank you, Dr. Elsie. What a wonderful introduction to the CUGH AfreHealth partnership. And as part of the CUGH board, I'm the relatively new member of the AfreHealth CUGH working group. So I really look forward to working with the group. I was just wondering if you could post the advertisement for the AfreHealth conference in Maputo in the chat in case anyone didn't catch the details of how to register, or the website perhaps that they could go to. And then I am so happy that you posed that question, how can we work together to improve global health education? And I hope that we can have a lively discussion about that at the end of all the talks. Okay, so without further ado, I'd like to turn it over to Professor Omaswa to talk about mutual learning in global health. And thank you, Prof. Omaswa, for joining us. I know you're in Geneva for a World Health Summit, so thank you for stepping out of that meeting to do your talk.
Yes, good morning, good afternoon, good evening all. And thank you for convening this meeting. And the theme is really great, how AfreHealth and CUGH can leverage each other's capacities in order to improve global health. I am motivated to speak about this topic from my recent meeting in the month of November last year. I attended the International Conference on the Future of Health Professionals Education, convened by the University of Miami, but attended by many people, including veterans, on this topic. And some of the things which I said at the meeting, apparently were new and exciting to the audience, and I'll share some of them with you. But I also know from my background a long time ago at Makerere University, where both Elsie and I trained. I was there long before her. We were receiving very regularly lecturers from the North, especially UK, but also US and Canada and Australia, who were coming to work at Makerere for spells of like 3 years. And many of these people went back to become leaders in their own institutions and countries, having benefited from the experience they had in Uganda and Makerere at that time. And more lately, a colleague of mine, I think one of the books Keith was showing is a book called African Health Leaders. I have co-edited that book with a man called Lord Crisp. The other one, that's that one. That one. If you see, look at the authors. It is myself and a gentleman called Nigel Crisp, Lord Crisp. He's also here. That gentleman got hooked up to me many years ago when I was the executive director of the Global Health Workforce Alliance, and we did many things together. In the end, he has written a book called Turning the World Upside Down. The book basically says that there is a lot for northern countries to learn from the south and southern countries to learn from the north, but he was mainly focusing on what can be learned by the north from the south. So CUH being CUGH, bringing us together, all the universities global, and then we in AfreHealth really provide an environment where this mutual learning can take place. The examples are many. You know, a student, a medical student in the US, in Canada, and another one in Kampala or Mozambique will be trained under different circumstances, but they all need to acquire similar skills. So how can the partnership between CUGH and AfreHealth make it possible for these groups of students to learn how to acquire those competencies with the resources that they have? And on top of that, I believe, I'm personally very convinced that if they visit each other and see the difference in the way in which health is practiced in the different environments, they will be so much richer, and the world will have health workers, doctors with a very aligned and well prepared to serve in their own countries, having understood how the rest of the world is. Let's take the example of patients who are used for teaching students. I spent some time in when I was training in cardiac surgery in some units in Canada and the US. And what struck me most was that when we did the ward round, we would start in the office, go over the files of the patients, and then go and see the patients, having discussed each patient in detail. And lo and behold, entering the ward, usually in intensive care ward, the patients are rigged onto monitors and so on. We never looked at the patient. We just looked at the monitor, made our decisions, and moved on. I was very struck by that. And then in Miami in November, I told the story of how just the basics of taking history from the patient, undertaking a physical examination of the patient before carrying out any investigation was such a key part of our upbringing of our students in AfreHealth, as opposed to a patient showing up, telling you a few words or being referred already, and all he gets from the clinician whom they meet is a form sending them for a series of tests. So I was encouraging the discussion was about, partly about digital health. Digits of the hand are 5 there. So I was touching patients is so critical. And I've been told many times by patients, I'm talking to them and I'm sending them somewhere before touching them. Doctor, please touch the child. Our humanity needs to be transmitted through the way in which we relate to the patients. And the need for our trainees and our doctors to be able to make diagnosis using 5 senses was brought very strongly to me. Some years ago, I worked in a 100-bedded hospital. After I became a cardiothoracic surgeon and so on, I went back to being a general doctor. With very limited resources, it is possible to make reasonably accurate diagnosis just with the history and physical examination of the patient. And I would like to market that and encourage our northern colleagues to come to Africa to see how we do this. And this is something AfreHealth and CUGH can do together. I would also like to see our students go to the northern universities and see how things are done there. And when they come back home, they are very likely to be very different people. How can we do this? Can we generate a fund to enable these students to move up and down? Not just the students, but even the faculty to come and spend electives, even if they are only 6 months in our part of the world, or even if they are 3 weeks, something like that. So that's my message about leveraging mutual strengths between CUGH and AfreHealth. I don't know whether it makes any sense at all, but there it is for your consideration. And Catherine, you may have to excuse me. This meeting is going on here. It's about to close. I need to be available at the closing ceremony as well. So if you don't see me, I apologize. But I'll listen in for as long as possible. Thank you.
Thank you so much, Prof. We really appreciate your comments. And I really love your digital health, meaning the 5 digits on each hand to examine patients. I definitely appreciate that. I was just wondering if there were any burning questions for Prof from the audience, since he might not be able to be with us during the discussion at the end. I will look for hands, and if there's anything typed into the chat. Okay, I don't see any hands at the moment. Prof, do stay with us as long as you can. If there are other questions that are typed out, then I'll forward them to you. But thank you again for your talk.
Catherine? Would that be
Oh,
all right?
yes. Sorry. Go ahead, Dr. Martin. Yes.
Thank you very much, Catherine. Dr. Maswa, in this book that you wrote at HS, you wrote a very powerful comment about the importance of strengthening government capacity, ministerial capacity, which is a major deficit in development, infrastructure, and financing. Can you talk a little bit about that gap in development and financing capacity building, please? Thank you.
Absolutely. This meeting which I'm attending here, this has also become a major topic of discussion. The main point is that, and this meeting is about health workforce. The biggest weakness is leadership, governance, and stewardship of health work for health workforce development. You find in the ministries of health, the capacity to plan and manage health workforce is limited. And we have discussed here yesterday and today how to build the capacities of ministries of health to be stewards, managers, and planners for health workforce development, including education and training, financing. So that book which you have shown, Keith, is from a study which Dr. Joe Bafford, who was then president of the New York Academy of Medicine, and I carried out, asking the question, what do ministers of health need to do their job better? And out of that, we listened to ministers. It was a global study. The message which came out, the one big message, an urgent message, was that many people became ministers of health from non-health background and needed to understand what is health health system, what are my role as the essential functions, public health functions in the country for me to lead. And they asked us to do a handbook for ministers, very short. We did that too. So that book, therefore, is basically asking us at CUGH and AfreHealth, what can we do to strengthen the governance capacity for health workforce development and management in the countries? And it is a job which we should take as one of our challenges and our priorities. Thank you.
Prof, I'd like to ask a follow-up question to Dr. Martin's one.
Yes.
Given what you just mentioned, how can organizations or universities outside of our African continent, so high-income country universities or interested parties, how would they go about participating in filling that gap of training for those in leadership positions who might not either understand health or specifically, how to understand how to manage or plan the workforce? Because, maybe countries don't just raise their hands up and say, we might need help. What would the mechanism be to participate?
Well, I think it is both sides. The northern countries first should take note of this need, and then together with us make a plan of how we can support these countries, AfreHealth and CUGH together. We've had experience where Harvard was running those courses, executive courses for ministers of health. They were using these same books, which you have seen here. But then the evaluation showed that the training, the experience was not grounded. And it didn't help the ministers very much. So we should be looking jointly at mounting a course which is jointly provided by Northern universities and African universities to build the capacity in the governments of our countries.
Thank you. I think Elsie has just put in the chat that AfreHealth already has a leadership program that we could support. Do you want to talk more about that, Elsie?
Yes, thank you very much, Professor Mensah, for bringing that up. And I'll be talking about it more at CUGH at a plenary on governance. We have a James Hakim Leadership Program. So far, we've trained over 60 young professionals. The aim is to make sure that as they go up the ladder, especially in academia, they are able to meet the needs of their communities. So it is, right now we've had 2 cohorts, but we don't have funding for it. It's an online program. It started during COVID. It's supported by University of San Francisco, University of California, San Francisco. Oh, am I getting it wrong? University of California, yes, San Francisco, through HASA. And it is very, very well sought out after, but right now we cannot continue with it because of funding. But this can be expanded. It's the same principles that are also needed for our ministers. So the same that we are giving to young professionals, we can actually upscale it and formulate one for ministers and higher cadres in ministries of health within the region. And if it can be supported, I think AfreHealth is a place where this can be done with the help of CUGH and other northern partners. Thank you.
Thank you. Well, that certainly sounds like something the working group can consider taking up, especially since Prof said that the current courses are not really grounded in sort of specific examples or quote unquote reality. And it might be quite useful to present case examples of countries, leaders who are currently in existence, but could use help, could use themselves as case examples or provide more concrete scenarios for where there are gaps. So thank you so much again for your talk, and we look forward to seeing you again if you are able to come back, but we understand if you cannot.
Thank you.
Our next speaker we have is Dean Abebe Bekele from the University of Global Health Equity in Rwanda, speaking in his capacity around COSEXA.
Thank you, Dr. Chu, and thank you very much for the invitation. For the coming 10-15 minutes, I'll be talking about the College of Surgeons of East Central and Southern Africa. The college, its main responsibility is in the training and the production of the surgical workforce. To give a bit of a context, at the moment, these numbers represent who we are. There are about 2 million surgical workforce, surgery providers in the world. Based on the recent tweet from the Director General of the WHO, the world needs about 10 million additional healthcare providers today to provide the minimum number of providers healthcare in the world. And if we look at the situation of surgeons in the country, the surgeon to population ratio in what we call the COSEXA countries is very low. Highest so far is Kenya, but almost all the sub-Saharan African countries fall below what is recommended by the Lancet Commission in the WHO. And what makes things worse also is the fact that the majority of these practitioners work in capital cities. Almost more than 75% of practitioners in Africa practice in major commercial cities. So to reduce the huge gap in surgical care, Africa has been engaged in several ways of producing practitioners. University-based residency programs are very popular. There are 3 colleges in Africa, in West Africa, South Africa, and COSEXA that train surgeons. Foreign trained surgeons continuously join the workforce in Africa, and there are several expats, both from South-South or North-South who work in the continent. The concepts of task sharing and shifting has also been introduced since a very long time. COSEXA is mainly set up to contribute what it can to the production of the healthcare providers. CUGH at the moment is composed of 14 African countries and 7 what we call partner satellite countries. The map is, I think, explanatory. It follows the concept of college without walls. It does not aim to build its own infrastructure or hire its own faculty and teachers, but utilizes existing human and capital resources across the different countries it functions in. And 64% of our accredited teaching hospitals are found outside of the capital cities. Hence, we're trying to prove a point that quality surgical education can be provided at the district hospital level, outside of big training hospitals. At the moment, we have 139 hospitals across 21 countries, 93 of which are involved in training. We have thousands of active trainings at the moment and more than 600 accredited trainers across these hospitals. And once accredited, hospitals remain viable for 5 years, and then they have to request for reaccreditation. Our training model is a classical college-based model where the first 2 years is dedicated to membership level training. Once trainees finish the MCS level, they sit for their qualification exams and they proceed to the fellowship level training. Fellowship, depending on which track trainees are in, are for usually 3 to 4 years. And we also have subspecialty level fellowship programs. After trainees do their general or orthopedic surgery, they can proceed to fellowship level programs. And these are the residency programs we have at the moment, starting from general surgery, the oldest, up to the youngest one, which is in cardiothoracic surgery. A few other programs are under development, including breast, upper GI, lower GI, hepatobiliary, and thoracic surgery, and thoracic and vascular surgery. And CUGH moved to the competency-based curriculum model in 2016. And as in any formal training, our focus is to produce the competent surgeon, not the expert, not the proficient, but the day one consultant who can be declared as safe and competent. Since the past 5-6 years, CUGH has moved significantly forward in its training. We use LMS-based integrated basic sciences teaching in anatomy, physiology, pathology, and basic surgery. Online assessment, formative assessment is done quarterly, 4 times a year. Case-based collaborative learning, mandatory courses. We have a very rich online logbook at the moment that has about 500,000 procedures recorded. I think it's the largest logbook kept by trainees, collective logbook trained by trainees in Africa. And there is regular training assessment and feedback provided by the local faculty. And this is the homepage of the logbook. Students use this in their cell phones, smartphones, and log in daily what they are doing. And a lot of e-learning has helped us implement and teach the trainees across the 21 countries. We also have a mobile surgical skills unit that travels from country to country. At the moment, I think it's in Mozambique, and hopefully it will move to another country to provide basic and advanced surgical skills training. As this graph indicates, our annual intake of trainees has significantly increased from just 7 trainees in 2002 at the MCS level and 6 at the FCS level to about 197 at the MCS level this year and 178 at the FCS this year. There's a significant increase in our intake of trainees. This year, in 2023, we have recruited, as you can see, about 1,000 trainees across the different disciplines. And this year is the record high intake in our basic at the MCS level. Our recruitment of female trainees has significantly increased, as you can see, from just 1 and 2 back in 2003 and 4 to about 100 this year. There's a significant jump in our number of trainees. We also work with a lot of funding partners, particularly in plastic surgery, who offer scholarships a movement from north-north, north-south, south-south collaboration, and that help us fly in several examiners and faculty across the different training institutions. CUGH's exam has two parts. The first one is the part one written exam, 120 MCQs in 2 papers, which has moved to completely digital since 2020. And the part two, the clinical exam, which shifted to OSCE at the MCS level in 2016, and which became fully virtual since 2020. The silver lining of COVID has been the rapid jump into transformation to e-learning. And structured short and viva exams at the FCS level. We have established our court of examiners about 7 years ago. And in general surgery, we have shifted to patient-less examination since 2017. And we work with a lot of partners. Our examiners come from all over the world. If those of you who have seen the CUGH exams, you can see how it's really partners based. Colleges across the globe help us, from the US, from Canada, from Australia, from Europe, and several academic institutions and individuals travel this long way to come and examine our candidates. CUGH is led by its council, 2 sitting members from the 14 countries, including Women in Surgery Africa. They have a chair at the governing council. And so far, we have graduated a little bit more than 250 surgeons across the various disciplines. Because of COVID, we had a certain dip around 2020 and 2021, but consistently the number of graduates has been continuously increasing. So did the number of female graduates, significantly from just 1 in 2 to 27, 29. One of the great successes of training under CUGH has been our ability to offer quality training locally and our ability to retain the trainees in the region. 93% of the graduates have remained in the CUGH region, in the XR region. And about 75% of the trainees remained in the hospital they were trained at. So the trauma from brain drain, the trauma from a departure from the countries has significantly been reduced by using the CUGH model of training. CUGH also has its journal, avenue through which its surgeons, its trainees publish. It has been about 27 years since it was established, and it has been used significantly by its trainees and local surgeons. CUGH has 3 main committees. These include the education research, the examinations, and the general purposes committee. I used to chair the examinations committee until last December. At the moment, I serve as the Secretary General of the college. And our main strength has been global health partnerships. As you can see from this slide, we work with a lot of partners globally. Colleges, academic institutions, tech companies, NGOs, and individuals, with a lot of them. That has been one of the biggest main strengths of what the CUGH has achieved so far. The partnerships offer our trainees and our examiners, our trainers, with volunteers to participate during examinations, in the writing of MCQ and viva cases. We have visiting faculty across 120 hospitals, volunteer journal editors, research advisors to the trainees. Several partners have helped us design courses, including research methodology, grant writing, grant management. They helped us in developing the basic sciences modules and a lot of research opportunity, grants, and mentorship. But the biggest, what needs to be mentioned, is the CUGH and RCSI, the Royal College Surgeons of Ireland partnership. This has been in existence for the past 15 years and has been transformational to what CUGH has been trying to do. And this is a very clear example of what the benefits can come out of equitable, well-managed global health partnerships. Dr. Chu, colleagues, thank you very much for inviting me to talk to you today.
Thank you so much, Dean Bekele, for that talk. And I'm very aware that most of you on this talk are not surgeons, but I did ask Dean Bekele to speak because I think the COSEXA program partnership, I think, speaks to a lot of things that the AfreHealth and CUGH are trying to achieve in global health. I mean, I think you pointed out the shortage of surgeons, and so the shortage of the healthcare workforce in Africa, specifically in surgery, which is not unique to surgery. And the fact that in surgery, and specifically, there are not enough university programs in each country to train all the surgical specialists. And so then now acting sort of as a consortium or a college across 14 different African countries, but using the local hospitals as training sites, I think is an excellent model that perhaps those in other specialties could also look at in terms of building training programs. And I think that, you know, COSEXA has come such a long way from just identifying sites for training to having a very robust online training program that offers the didactics, the parts that sort of the benefits from a traditional surgical program at a university that some people working in rural areas but are part of COSEXA training wouldn't get. And I think we can see from the high caliber of those that come to take the exams and the very high pass rate that, you know, they are learning the academics that they need. And then you also pointed out, I think, equitable partnerships, especially your long-term partner with the Royal College of Surgeons in Ireland, because I think having gone on for 15 years, it is one that has been built with trust and over time. And I know that they've also been open and adapted their support in the ways that you and the COSEXA leadership have asked for. So it hasn't just been a one-way, here's what they're going to offer. But, you know, if you say you need scholarships, if you say you need this, that, and the other. And I know now the newer partnerships with some of the plastic surgery organizations offering scholarships for trainees, I think is also an excellent way to fund or to make it possible for more trainees to come in. I see that Quentin has a question now. Would you like to ask that now, or you want to save it for later? Feel free to go ahead, Quentin, if you'd like. I'm sorry, Quentin, you're still on mute. If you want to rephrase your question.
Hi. Sorry. A question I can't refrain from putting, and that is, as a pathologist, there's an enormous shortage of pathology in Africa, and surgeons should be connecting with the pathology groups in Africa, because for many of the surgical interventions, you need an effective diagnosis, especially in cancers and things like that, to be able to know how to proceed at different points. So the shortage of pathologists in Africa is absolutely dire. There are countries that have no pathologists, some have one. So I'm just curious, has that ever come to the table in your organization, COSEXA, about communicating this, or do you perceive it as something to address, or critical shortage, or you just proceed? I'm just curious how you view it.
Thank you, Quentin. That's a great question. COSEXA sits under the East African Community Health Council, under which are 5 colleges: the College of Ophthalmology, the College of OBGYN, the College of Nursing, Physicians, and Pathologists. All of us sit under one Senate. So we talk to them, we discuss with them, me as a surgeon individually, and COSEXA in general, feel pathology is the most underserved discipline in clinical medicine. So we closely work with them.
Yeah, hopefully at the AfreHealth meeting, we're considering a panel on that. So anyway, I'm glad it is part of it, because it is something that is often under valued, and I think something really needs to be done about. Thank you.
All right.
I see another hand, perhaps also for Dean Bekele, Carol McCammon.
Hi, can you hear me? Okay, good.
Yes.
I represent the emergency medicine specialty, and similar to the pathology point, I just wanted to see if there's any work with the emergency medicine community to support the surgical community, because obviously that's an important piece of infrastructure that has a great opportunity to be supported and built. And I think that very well fits along with the discussion at hand. So that's just my question. Thank you.
Thanks, Carol. Well, unfortunately, the focus on emergency medicine as a discipline in Africa is at an infancy.
Right.
Well, there are only a few countries in Africa that have started emergency medicine as a residency or a fellowship. Ethiopia started in 2014, and I think at the moment there are 2 residency programs there, but there are many countries that don't have emergency physicians. So I must admit the focus is not, as strong as we want it to be. Hopefully things will change in the future, but it's the white elephant in the room.
Well, I would say that I'm definitely on board to assist in any way that you guys would see that there would be any partnership that we could promote. Thanks.
And maybe just to also respond to Carol's question. So you probably know Terry Reynolds, who works at the WHO now, an emergency physician, I think originally from UCSF, a long time ago. But they've organized sort of emergency systems as with surgery and operative care kind of linked to it. So it goes from emergency to surgical to critical care to operative care, or ECHO. And I think there was just a paper that came out about that in the bulletin of the WHO, which I can post here a bit about it. So I think at least at the higher levels, there is link now with emergency care and surgery. But I think Dean Bekele's point is very well taken. On the African continent. Emergency services are not that well developed. But the majority of the surgery that happens is emergency care. We haven't really even gotten to the elective, more subspecialized care. I see that Keith Martin also had a question around. Keith, do you want to go ahead and ask your question to Abebe?
Thanks, Catherine. I don't want to hog the question, but quite briefly, Dr. Bekele, just first an invitation to everybody to join the sessions this week and next week, led by Dr. Key and others on strengthening the surgical ecosystem. Second, we contact us, Carol, because we worked with Dr. Tupensis and others, including the WHO, as Catherine mentioned, on strengthening the emergency pre-hospital to hospital care. So email us on that. But Dr. Bekele, can you talk about strengthening the surgical ecosystem, the opportunities to task shift to nurses on some surgical training, and also strengthening the entire infrastructure in terms of not only people, but power, supply chains, water that underpin the ability of any surgeon to operate. Thanks so much.
Yes, thank you, Keith. Well, a classical example of what surgical systems look like is what happened during COVID. Africa survived COVID based on what it had as surgical ecosystem. It was the surgical workforce that were able to intubate. So the surgeons, residents ended up being distributed across the ICUs, the different hospitals. It was the theater nurses who managed intubation, pulmonary care. It was the ICU nurses. It was the disinfectants used by surgeons, the hand wash, the alcohol, the whatever. The ICU, the ventilators we have, at some instances, theaters were changed into ICUs. Anesthesia machines were converted to ventilators. So a classical example of what system strengthening looks like is what we did during COVID. And system strengthening refers to nurses, anesthetists, general practitioners, surgeons, supply chain management, financing, the policies. We need to really work on them. And there was, in fact, a strong stand among the surgical community a few years ago that preparing for surgery, the surgical systems, means preparing for the next pandemic. And that's how I think we should look at it. We need to strengthen the surgical systems. So unfortunately, the college, CUGH, is now mainly focused on the production of surgeons. But hopefully that integrative surgical system strengthening work eventually will come when we start working with the different colleges.
Okay, I think in the interest of time, we've got one more hand up. We'll let that this question from Ibrahim Umar, and then we're going to move on to the next speaker. Would you like to ask your question, Ibrahim?
Yeah, thank you. Thank you so much for the opportunity, Kathleen. You know, my own is just a concern about the surgical professionals, those that specialize in surgery. You know, training in surgery is very challenging. And if you goes by the SDG stipulations that talk about recruitment, training, and retention, in Africa, this is really a challenge. One, brain drain. Two, finances. Three, commitment and political will. And if you talk of equity in global health, an African proverb that said, he who comes to equity must come with a clean hand. The issue of brain drain, is it a challenge or not? If it is, how do you address it? Just of present, so many medical doctors are applying out. And then specialization also is another issue. People get difficulty in passing their primaries, talk less of being specialized in that aspect. Just applying ideas. Thank you so much, Kathleen.
Did you catch that question, Abebe? I think it was about equity and training and in surgery and some of the challenges to get through the various steps.
Yeah. I think Ibrahim also wanted to know about brain drain. I think we can reduce brain drain. I don't want to call it brain drain. It's just relocation of professionals. If they serve the continent anywhere, they're serving the poor. The first thing I think is to understand why professionals emigrate or migrate. In my experience, money is not usually the case. It's usually lack of opportunity, need for further training, research, opportunity, family reasons, political, peace, things like that. It's not about salaries. So if we understand why people migrate, the reasons are different across the different countries, then putting in mitigating measures will not be that difficult. CUGH has done it. CUGH has managed to offer surgical residency positions in the different district hospitals. That means doctors don't necessarily need to travel abroad in search for residency programs. And there is data out there that shows you probably will remain in the country where you did your residency. If it's abroad, you remain abroad, you stay abroad. So we have managed to do that. The second is try to understand physicians and surgeons. These are human, they have needs. They want to do research, they want to progress in career, they want peace, they want family, they want a decent life. So policies and working situations, as much as possible, should be conducive to them. And it can be done. It can be done. If country A has done it, why not country B? The last thing I can talk about is the way we train our physicians and surgeons. If during their residency, 5 years with us, if we try to inculcate the idea that they are here to serve the poor, that God put them in this world for a reason as surgeons, that they have this national responsibility, the professional responsibility to do what they can to help the poor, to help the underserved. Some of them might believe it. Some of them might have really changed heart, changed mind. So they may decide to stay there. So not only just opportunities, but the way we train also has to improve and change. Thanks.
Thank you so much, Abebe, for those responses. And just to emphasize that the quality and the methods around healthcare workforce training and education is so important, which I think is something true to AfreHealth and CUGH's heart. In the interest of time, we're going to move on. I know that there will be many more lively questions in the discussions, but let's move on to our next speaker, which is Quentin Eichbaum from Vanderbilt University, speaking about a global health survey. Quentin, go ahead.
Sorry, I thought someone else was before me, but was Dr. McGunsey not before me? Can you hear me?
Yes, go ahead.
Give me a minute. I'm looking for the upload button. Sorry. No, hey, listen. Can Dr. McGunsey go ahead? That was the original order. I was second.
Yes, no problem.
I have to
Dr.
answer.
David Muga. Yeah, no problem. Dr. Muganzi, would you be able to do your presentation next?
Yes, sure. Thank you very much.
Thank you so much for that.
My name is David Jody Muganzi, as I was introduced, and I'm the president of the student community at AfreHealth. I will be sharing experiences and thoughts and ideas on the role of students in promoting global health in Africa. So I will make a presentation. We're using another device, and I will remove my video. All right. So I will be speaking about the role of students in promoting global health in African institutions. In the current era of ChatGPT, making such a presentation is tasking because someone can punch this into ChatGPT and they will get the answers. So I have a task of doing better than ChatGPT. I think there are some echoes. Thank you. So with that, I will try my best to do more than ChatGPT. I will share stories, and I hope that these stories will get us to think about this topic better. So I will start with a why, because as we all know, if there is a strong why, then we shall have ways of finding the how, no matter the cost. Currently, there is a need to advance global health in Africa, with Africans at the forefront, or African countries at the forefront. And we know that the advancement of anything goes as far as the young generation can contribute to it, because these are the people who will own it and build it and then transfer it to the next generation. So African health professional students have the mandate to imagine and create global health that we all look up to. One with health equity at the forefront and health systems that are providing services that are of quality to everyone, wherever they are. My first case scenario is that of students at the front line during COVID-19. When the lockdowns were instituted across countries, I left school and I returned home. Most of my colleagues in other countries did the same. At that time, I was serving with the FAMSA, Federation of African Medical Students Association. And then an idea came up to get health professional students across the continent to contribute towards the health crisis that was happening. And with that, with colleagues from across the continent, from South Africa, from Nigeria, from Kenya, a technical working group was developed, which aimed at getting health professional students at the front line. And one of the challenges during the pandemic was the infodemic. There's a lot of information that was coming up, and there's a lot of information that was not accurate. there were a lot of papers that were published. So one of the main things that the technical working group did was have a research group of students read papers published weekly from the major journals, from Lancet, from Nature, and also track what the WHO and the different ministries of health were saying about COVID-19. And these were analyzed and created into a booklet, a bulletin each week. And as you can see, the bulletins were produced in English, Arabic, and French. And we all know that these are the major languages across the continent. This is one of those stories that shows how much health professional students can contribute to it.
Reminding the person.
The second case scenario is that of health professional students challenging the status quo on health quality. During my introduction, Dr. Catherine mentioned that I work with the patient-centered care movement Africa, PASEM-AFRO, which is a community of practice for health professional students to build a generation of health workers that will transform healthcare on the continent to make it patient-centered, so that the quality of care that is provided by health professionals puts into consideration the patient's values, their needs, and not only what happens in the clinic, but the entire health systems, that the decisions made at policy level, the decisions made at academic institutions are putting the patient at the center. And this started out of a conference by health professional students. And as you can see, the community has grown. The picture in the corner shows the chapter at the University of Cape Town. I chose this because Professor Catherine is in South Africa, and to show her some of the students. So this is another case scenario that shows what health professional students can do to advance global health on the continent. And then the third case scenario is that has the latest. Together with the CUGH TAC committee, the AfreHealth students thought of a project on global health carriers. A protocol was put together and a survey was done. The results of this survey are going to inform the discussion during one of the satellite sessions at this CUGH conference. And the results of this survey have the potential to carry forward the conversation on decolonizing global health carriers, on supporting health professional students across the world, not only from Africa, but from the global north, to make the most of their global health carriers. We got responses from across the continent, and this is a typical example of how health professional students can leverage the partnership between AfreHealth and CUGH to advance global health. I hope that members from attending this will show up for our satellite session on Friday. So with that said, what can you do? I'm going to share a few insights from my experience and from the few projects I have, the case scenarios I have shared here. And my insights are going to be for two major categories. I believe there are health professional students like me on this platform, and the health professionals, the policymakers, and the different administrators. So the first is going to be to the health professional students. The first thing is to take interest in learning the different skills that require you to enter the space of global health. As we all know, there are many aspects to global health. There's a lot that one can do. There's a lot in terms of research. There's a lot in terms of health profession education. There's a lot in terms of policy. So as health professional students, the first thing that one can do is to identify an area of interest and then get on the journey of learning the skills that are required to contribute towards that area. I'm stressing learning because I believe that when you start learning and you become productive, the opportunities will present themselves. For the case scenarios that I have shared, all the students that came together to work on this had a unique set of skills that enabled them to carry out these projects. And then secondly, is you have to make yourself available. The different opportunities that I have shared, for example, the latest one, which is the project between the CUGH, TAC, and AfreHealth, was available to students that were on the TAC committee and the students that are on the AfreHealth committee. So it is necessary for health professional students to make themselves available by applying to serve on student bodies like the CUGH, TAC, and the AfreHealth Student Committee. Another third point for students is to find mentors. Mentors have the ability to propel you further than you can go. Mentors have seen a lot of that you are going to go through and can guide you on the right things to do. They can support you in terms of resources. They can point you to the right people to talk to. And all in all, it is always good to have someone having your back. And the last thing is imagine and create. All the three case scenarios that I have shared are not from the textbooks. They're not recommended by anyone, but health professional students imagined what could be. And they did not stop at imagining. They went ahead and started creating and worked on their creations to the point that there can be impact. So if there's something for health professional students to take from this is imagine and create. And then for the other stakeholders, the policymakers, administrators, faculty, and members from the civil society. The first thing that I think you can do is mentor the young generation. At the recently concluded AfreHealth Symposium, I got to meet Professor Bukusi. And in her session, she was talking about mentorship. I learned a lot how to be a better mentor and also a better mentee. And as I speak right now, she is supporting one of my research projects. And this, despite her busy schedule, the time that she offers has propelled us to further points on our journey. So the first thing that faculty and policymakers and other stakeholders can do is offer mentorship, offer time. That time is very, very valuable. The amount of knowledge that you can pass on to the younger generation can make a very, very big impact in terms of advancing global health and in terms of supporting students to carry out their role in advancing global health in their institutions and on the continent. And then secondly is sponsoring students to carry out these activities. As I showed you, these different case scenarios had, I should say, good impact, but they were not funded. The COVID-19 project was not funded. The CUGH tax survey was not funded. PASEM-AFRO is not funded. But this shows that students, even when given the minimum resources, can do so much and take things further because they require very little resources in terms of money. And when given, the returns on investment will be high. The other recommendation to support students to carry out their mandate is offering apprenticeship. The first point that I gave to students was for them to get into spaces, to learn skills that will enable them to contribute towards global health. But they cannot learn these skills from just the internet or textbooks or listening to mentors. They need spaces to practice. They need spaces to fail. They need spaces to see how things really are. So I hope that the AfreHealth partnership and with CUGH will provide more of these spaces for students to learn, for students to fail at trying out things, for students to implement things. And then lastly is financial support. I will say it as it is. Students need money. For students to do what Professor Omaso said, moving around to learn what is happening in other places of the world, there is need for money. And there is need for people to commit to providing this money. And as I mentioned, the return on investment of this money is high. It is very high because the skills and the experiences that these students will learn shall be with them for the rest of their life. And they will most likely pass this on to the next generation. And with that, I just want to mention the other thing that health professional students can do is make sure that they work with students across the border. As you have seen the case scenarios I have mentioned here, Africa is divided by colonial borders, but this does not have to be the case as we work on global health. As we work on global health initiatives, there is need to, because of the internet, there is opportunity to collaborate. And when you collaborate, you get to learn so much, you get to do so much, and you get to be propelled so far. So with that, I come to the conclusion of my presentation, and I want to thank Professor Catherine for putting this together. It has been very, very insightful.
Hello, everybody, and thank you for inviting me to this ACWG satellite. I've been involved with the group from the beginning, so it's great to continue participating. So the study I want to talk about was a very large study that we did as the pandemic was starting, and took almost 2 years to complete, but I think it has relevance to global health overall, and in particular, certainly if we go through another pandemic. There are a lot of lessons learned. The idea of this study was to look at the impact of the pandemic on academic global health programs, and we studied them extensively internationally, both in high income and low and middle income countries. So the design of the study is quite a high-powered study that is used in epidemiology and medical education, and certainly has been used in certain African contexts as well. It's called a mixed method sequential explanatory design. And how this works is there's a phase 1 and a phase 2. Phase 1 of the study is quantitative and phase 2 qualitative. So in phase 1, you do a survey and you accumulate data. And in phase 2, you select particular respondents from phase 1 and you do in-depth interviews with them. So that makes it almost quite a lot more time consuming. But the power of a study like this is that rather than being perplexed by some of the responses in the first part of the study, you can contact certain participants and interview them verbally. And that's what we did. We took 17 interviews and about 40 minutes each to get more in-depth explanations of some of the responses that were done in the first part of the study. So the design of this took a long time to figure out, but we decided to look at three, besides the demographics of the study, we looked at educators involved in global health, we looked at researchers involved in global health, and we looked at administrators. What the impact of the COVID-19 pandemic was on each of these, educators, researchers, and administrators. And then we interviewed a mix of all of these three groups. So here's a diagram of the study. Phase 1, quantitative data collection, then you analyze it. Based on the responses and analyses, you go to phase 2, then you have in-depth interviews, then you analyze the interviews, and in the last phase, you put both of these analyses together and come to specific conclusions. So we had quite a wide distribution. As I said, this was a large study in 36 countries involving 230 academic global health programs. And we did this by contacting a variety of global health networks and organizations in countries, North America, South America, Europe, in Africa, in the Middle East, and in Asia, and in Australasia. And that's how we managed to accumulate 230 programs. This study was eventually published. I designed it and led the study, and it was, if you want to look at it, this is where it was published. And I'm going to go through some of the key findings of the study. There's an enormous amount of data, so I don't have time to go through all of these, and I'll just touch on some key points. In terms of the demographics of the programs, what became immediately apparent, and I think there's some discussion later on at CUGH about this issue, but where are academic global health programs located? and we couldn't break through the ceiling. 85% of them are in high-income countries, and only 15, give or take a couple, are in low and middle-income countries. And you may wonder, why is there that big difference? And it has to do even with the notion of decolonization. For us, global health is really a bit of a Western construct. We kind of construct global health, and in low and middle income countries, one could argue you live global health. Whether that should be the case or not is something that we need to debate. But rather than harping on the rest of the demographics, I'll give you some of the key findings of each of the three groups, starting with the educated. So here are a lot of some of the raw data, and I've tried to highlight some of them, but I'll just jump immediately to some of the key survey findings. We were curious whether the pandemic, how it impacted scholarly output. And there were some surprises. You might think, for instance, that the pandemic would have decreased scholarly output. But to some extent, and in high-income countries, it actually increased by 45% said it actually increased their scholarly output. LMICs, again, let's be very clear, they're a lower number, said it did not. And one of the reasons it probably increased scholarly output is that people stayed at home and they had more time to write. And I know that that is the case with certain journals that I was involved with, either as a reviewer or submitting articles, told me their submissions had increased threefold during the pandemic. And so those are probably certain kinds of articles which can be done sitting at home and writing, and not others that require ongoing field work. Nonetheless, some did also report, and LMICs, low and middle income countries, actually reported somewhat more of a decrease. So about a third reported a decrease in scholarly output, and some reported no change. In terms of, for the educators, how travel was impacted, there was a high level of suspension of outgoing travel. For high-income countries, 92% of outgoing travel and 66% of incoming travel was impacted. That is not surprising to me at all, because in global health, for better or for worse, and it's actually not a good thing overall, most of the travel is unidirectional. So high-income countries descend upon low and middle-income countries. So when the pandemic hit, this affected high-income countries more than low and middle-income countries, who were impacted much less than we were. Other key findings for the educators were program coordination. How did their programs respond to the pandemic, and how well was the response to the pandemic coordinated? Well or moderately coordinated. High-income countries said it was pretty well coordinated, and low middle-income countries maybe less so. One of the reasons for these inadequate coordination for high-income countries was a lack of central coordination or leadership support. I'm not surprised by that. Many high-income country academic institutions were struggling with many things at the same time, particularly medical centers had to look into how they were managing their healthcare, and global health became less of a priority for many of them. For the lower and middle income countries, what was mostly impacted and affected the program coordination was education delivery and content issue. In terms of distance or virtual learning, both groups, high income and low middle income country, both quite quickly implemented virtual and in-person versus in-person training. So that was a key finding of this, how well the virtual learning platforms actually functioned. And that is a major takeaway from the pandemic. Funding, you could ask very clearly, how did the pandemic impact funding for educators? In high-income countries, there was significant reduction, 35%, moderate reduction, 14%. LMICs often responded they weren't sure how it was impacted. And that can possibly be understood, that the funding departments maybe don't put out the data as clearly as high-income countries might that have larger grants offices. So when we did the interviews, those were the results of the surveys. When we did the interviews and did these by thematic analysis, what people said in the interviews was that there was elements of good coordination, was generally, it all hinged on effective communication versus slow decision-making where the coordination was not that good. Transparency was a key issue. If the leadership were transparent about what they were doing, this resulted in better program coordination. Flexibility, programs that were flexible did better, and programs that had proactive leadership had much better coordination and response to the pandemic. In terms of what emerged from the interviews about virtual learning, few reported, especially in high-income countries, problems and lapses in education continuity. Zoom, as we all know, became the go-to platform that everybody used. Many people predicted in their interviews that they would move to a hybrid model of teaching in global health that involved hybrid online and in-person teaching. Some of the concerns about these virtual programs in learning for the educators in the interviews were how did this impact program accreditation, and particular the clinical programs were very worried. How could they more effectively teach hands-on clinical teaching with virtual platforms? And we were in touch with three of the major virtual teaching platforms, and some of them adapted pretty well and provided videos for online clinical teaching. So I think we'll see more of that as we go ahead. So those are a couple of the key findings of the pandemic on educators in global health. On research is some of the key findings, these are just raw data, were that it had a significant impact on research, not on education. Again, this is on research. 75% of high-income countries and 34% of low middle income said that it impacted their research. Reductions in funding were reported more so in low and middle income countries. It's interesting why that would be. Maybe receiving funding from high-income countries, those sources dried up because people couldn't travel as much to low middle income countries, but the impact on funding for research, again, not education, was higher on low and middle income countries. Many reported no change. Scholarly output was decreased, less so in high income countries, low middle income countries. Again, I think that is because the field research, or research, which we're talking about here mostly, was impacted due to reductions in travel. So it affected low and middle income countries more so. Virtual collaboration, we asked the interesting question whether they thought virtual collaboration could replace in-person collaboration. High-income countries, no. Interesting, low middle income countries, many thought it could somewhat replace, virtually then entirely replace. High-income countries thought 70% thought it could somewhat replace in-person research. And there was also an interestingly high number of low and middle income countries thought that virtual collaboration in research did have a place. In terms of the interviews in phase 2 about research, some of the comments were LMIC said every corner of research was impacted. Some said it was too early to assess. Clinical researchers said reduced output was due to increased clinical work. As we know, the COVID pandemic put a lot of stress on clinical workers, and so because they were more preoccupied in dealing with clinically with the pandemic, they had reduced research output. And then this was a mixed kind of response about how research was impacted when people stayed at home, but whereas the educators were able to write more, the researchers were more impacted due to the reduction in field research. So other problems were poor internet connectivity. People missed the social interaction of research, reduced networking for collaboration, which is often in-person conferences had people meeting each other in person and they set up collaboration. So people cited that in interviews as a reason for reduced research output. Lastly and thirdly, the administrators, these are the people who run the academic programs. How were they impacted? And clearly what researchers need to worry about most is risk. And here's some raw data, and I'll just touch on some of the key findings. We had asked them, these were some very nuanced set of questions about whether and when and what level of risk they would allow their students and faculty to travel. High-income countries, all of them except one, had a very low risk tolerance for international travel. And so what that resulted in is that many of their students in global health and faculty resorted to what we call global opportunities, global, local. They started working in low resource settings within their home countries. Interestingly, low and middle income countries generally had a higher risk tolerance for travel. Not clear why that is. Maybe it just was a bit of a confounded because they travel less, but they seem to indicate that they would have a higher risk tolerance. And then several had a medium risk tolerance, and we asked a lot of questions on what this depended on. And they would cite what was the vaccination status of the travelers and the host. Were the travelers vaccinated? Were the hosts vaccinated? Were they adhering to safety protocols? How much PPE did they have? Did they have masks? Was COVID testing available in the host country? So this all depended on how these factors impacted their risk tolerance for travel, and whether they had institutional committees to evaluate travel requests and didn't let anyone just travel independently. The interviews, the phase 2 for the administrators revealed a lot of some positive and negative aspects. There was an impressive use of new and creative uses of technology, a lot of dedication by the commitment by these health staff and administrators. Local opportunities emerged. At the same time, the whole debate on decolonizing global health took even more prominence. There was a stronger commitment that people would commit to international partnerships, and there were new opportunities that arose. Some people felt as a result of the pandemic. Clearly, there were many negative effects that came out in the interviews for administrators: mental health care issues of healthcare workers, stress on faculty, deaths of colleagues, impact on clinical training especially was a very worrisome aspect for the administrators, and enormous restrictions on international travel. So this study, and I'd urge you, if you're interested, to read the paper, had lots of data in it. I've just touched on a few of the findings. It had some limitations in the demographics. There were relatively low number of low and middle income countries. And I think that's a reflection of the status of global health academic programs in low and middle income countries. We had a disproportionate number of academic programs in the US, really, so it's a bit skewed towards the US. The interviews are only done in English. We need also to remember this was a cross-sectional design, so the actual study period took place over 2 months and data analysis over 3 months for the interviews. COVID was fast changing and dynamic throughout this period, so one's got to be aware of that. And we didn't do a coded comment analysis, which one sometimes does in qualitative interviews, because the interviews reveal sort of quite varying kind of comments, so they were not susceptible to were susceptible only to thematic analysis. So the conclusions of these studies were: there were some expected findings, there were some less unanticipated findings. We were impressed by the immense adaptiveness and learning agility and innovation that occurred during the pandemic, the very effective adoption of virtual learning and collaboration virtually, that people learned to collaborate virtually. There were lots of similarities and differences. The main differences between high-income, low and middle-income countries were the travel restrictions, and this has mostly impacted high-income countries because the travel is so unidirectional. Low and middle-income countries, the reduction in funding and lack of resources was a major difference between high and low and middle-income countries who have less funding and fewer resources. And again, these differences between high-income, low and middle-income countries are mostly due to differences in resources. They've established power differentials in global health practices, and funding of collaborative programs that unfortunately are still largely controlled by high-income countries meant that the way they responded to the pandemic was pretty different, because as things stand, still the collaborative projects are largely still in the hands of the funding in the hands of high-income countries. What's going to happen to global health post-pandemic? Certainly virtual collaboration, teaching and research will become a mainstay of global health. Everybody's predicted that this would happen as a result of the pandemic. There are also changes in field experiences. In-person collaboration will likely decrease a little bit, and there'll be a move towards virtual. Many students, we think, may opt towards local experiences, which they didn't as much before. We'll have to see. Funding may decrease. I'm not sure. I think we're seeing a management in the shift from high-income countries to low and middle-income countries. However, the field of global health was significantly transformed, I think, post-pandemic. And that, coupled with the move towards decolonization, and that's why we asked Professor Volmek at the last ACWG to talk about the future of global health in a post-pandemic world with a decolonized mindset. So it's going to be very interesting, and I think there are some of the impacts already emerging. So the conclusions are of the study that the pandemic disrupted academic global health programs in high and low income countries in expected and unexpected ways. Programs had unanticipated reductions in education funding, negative impacts on research programs, and reduced, but in some levels, increased scholarly output. Many programs reported well-coordinated responses, including virtual versus in-person collaboration. And finally, the pandemic will have lasting impacts, we believed at the time we published the study, which was now about a year ago, with regard to education, research, and administrative programs. The jury's still out. So to repeat, this is, if you want to look at the study, I coordinated here my collaborators, Tracy Rabin, Jenny Saman, James Hudspeth, and two interns, and Jessica Everton. Here's the paper that was published in the Annals of Global Health. So happy to answer any questions at this point, and if you want to get in touch with me, here's my information. Thank you.
Thank you so much, Dr. Eichbaum, for that talk. And, I think that it's very revealing that COVID pandemic really affected all sort of healthcare training programs and research programs, but obviously for global health, where one of the critical parts of the research collaboration and training is cross-country movement, how it was really changed. I mean, I think some of the interesting things about how differently the impact was on high income versus low and middle income countries, for example, that in high income countries, some people were able to actually be more productive and certainly reduce the number of publications in a much sort of impacted that less. And I wonder if that's because in high income countries, in the topic of global health, there's more publications on sort of editorials and systematic reviews, whereas those in low and middle income countries are actually doing the primary data collection, and then they weren't able to go out and do that. Your comments on the fact that maybe there'll be fewer global health traveling programs from high income to low and middle income countries. I don't know if that could be true. I think from our own Center for Global Surgery here in South Africa, there's been an explosion of students wanting to come over now because the pandemic restrictions have lifted. But on the other hand, I'm wondering if that necessarily isn't a bad thing if more global health students want to stay in their own countries and do local projects, because I think that is quite important. And perhaps there may be more of a shift to fund global health students within one of the African countries to fund themselves, because I think that, oftentimes there's the fly-in student, but then the local student doesn't get the opportunity as well. And then the other thing we noticed during the pandemic is that in research partnerships, there was more reliance or more responsibility placed for the local collaborators. So before, there was more of the traditional sort of high-income PI flying in, overseeing the project, but because they weren't able to travel, they actually just had to give more responsibility to local collaborators. And then perhaps in the discussion, or if anybody in the audience wants to comment if they had that type of experience, but I do think that there were local collaborators that benefited from that, because then they got more trust put into them and perhaps it built more capacity in that way. I don't know, Quentin, if you want to respond to any of those comments.
Yeah, I mean, it's a good point. And as I say, the study was published a year ago, and I'm fascinated by your comment that you've seen an explosion of people traveling. Is that maybe a temporary thing? They want to do that? Is that localized? Is that going to happen? I was very curious, for those of us who have been involved in the decolonization debate, whether there might be some circumspection about this incredible amount of interest in global health, and whether people might be rethinking it a little bit and not wanting to do certainly the short-term global health experiences. But at the same time, I'm not surprised that initially everyone wanted to get out and travel. I'm curious whether that'll be a lasting impact and whether the pandemic will have had no impact on it. So maybe there are others on the call who can relate their experiences, whether this has happened. That's my one comment. My second comment that I would be very interested in hearing other people on the call discuss. And I know Stellenbosch has a global health institute, but why, what are the impediments to establishing global health institutes in low and middle income countries? Is it because you live global health and we do global health? Or are there other reasons? Is it a resource issue, or what is it?
Thank you. Well, I don't want to put anybody on the spot, but Quentin did ask if there's anybody that wants to comment either from the Global South or North about whether they experience more or less travel from students. And Ian Cooper, who's the current acting head of the Department of Global Health here at Stellenbosch, is on the session. So I don't know if you want to respond to Quentin's question around what are some of the barriers or lack of interest by universities to establish institutes of global health. We have one here at Stellenbosch, but I don't know if you want to comment on that, Ian.
Is either not there or muted.
Okay, Ian, I don't know if you heard the question, but that's okay. We can continue. All right, well, why don't we go to our last speaker, Dr. Dyken. Yeah, sorry.
He wrote in the chat he can't unmute.
Oh, sorry, he cannot unmute. All right, sorry, Ian, I need to unmute you.
Dalala's muted everybody. So Dalal, are you able to unmute?
Yes, I could. Who would you like?
There I am.
There we go.
Okay, sorry about that, Ian.
Sorry, I was tapping madly on this thing and it wouldn't.
All right. Sorry, I put you on the spot about asking about global health programs on the
no
continent
problem.
and maybe some barriers. Yes.
I was tempted to respond before you actually spoke. And yeah, because I mean, I guess I was very cynical myself about global health before I actually got moved into a Department of Global Health, and then I had to rethink it. And I think it is very much because global health has been owned by the North with particular view and perspective on global health. And it was actually Jimmy Vorming who challenged me to say, well, we actually need to rewrite the thinking around global health from the global South and say, it's not about North-South, it's about equity. And that is what we must be driving. And I think that makes the difference for me, but between public health more generally and actually a focus on global health is that that understanding of a focus on equity as a key driver into, I mean, there are many other things as well, but I think that's certainly what lies behind as a key focus behind our department. I come from the perspective of a Center for Rural Health, and I mean, I feel completely comfortable within global health because rural health is all about equity. So it very much fits with that. But many people I speak to in the South do say, what is this global health business about? And, you know, what are you talking about, and why global health? So I think there is still a lot of skepticism around that. And I would say that's probably the prime reason why there aren't more institutes of global health. On another note, in terms of the discussion, in terms of impact on travel, I think COVID for me was wonderful reset. I was able to say, why do we travel? And what are the benefits? And what are the harms? And I'm fascinated that CUGH organizes a conference with a major theme around climate change, but says everybody who's going to present must be there in person. Yeah, Keith's not on is he still on the call? I'd love to hear a response to that, because I think we need to be rethinking that kind of approach if we're serious about climate change, which to me is an essential element of global health as well. Thanks, Catherine.
Great points, Ian. Quentin, did you want to respond to that, or?
No, I think I'm on board with what you're saying, and I'm curious, you know, whether I'm not sure I fully understood. So I think your element, your switch towards seeing the need for what we call global health, and there's talk about changing that name, how you rethinking it in the global South. And I think a better word may be to add the word equity at the end of it, global health equity, rather than global health, because equity is a key part of that equation. And if you put equity or public health, I don't know, I think viewing it as a public health rather than global health issue may be the kind of shift we need in thinking. So, but we tried very hard in the study to find so-called academic global health. And we had to be focused on academic, not only because CUGH is academic about universities, but it would have been very difficult to find researchers, educators, administrators in NGOs, because NGOs are a whole different kettle of fish. So it was academic, but I'm not, it's an interesting point. Will the one impact of the pandemic maybe be that there is an increased interest in LMICs in what we still call global health or not? Maybe too early to predict, but I don't know if anyone has seen that kind of interest peak, or what we need to do about it, or whether we should be doing more in LMICs to promote it, even if just in the interest of equity and pushing the agenda towards decolonizing the funding streams and the travel streams and all of that. So I'm curious, where this will really lead. But but I'm curious if other people, I don't know if anyone else wants to respond, whether you've seen either in HICs more travel or in LMICs less travel, or whether people are rethinking the whole travel aspect of global health.
I think if anyone has any comments, perhaps they can type them in the chat, and then we can get to them in the discussion. I just wanted time to get to Dr. Dyken's talk on building capacity and the platform that CUGH has created, and then we can reinitiate that discussion as well. And yeah, Andrew has typed in his own comment about majority world. All right, Dr. Dykens, do you want to continue with your talk next? We may have to unmute you. Hang on one second. Apologies. Okay.
Okay, greetings.
You're unmuted. Yeah.
You can hear me, huh? All right, and the screen is visible as well, I presume. All right, great. Well, thank you all so very much. This is absolutely an honor to be able to present this capacity strengthening platform to the group. I'm thrilled to be with you and really grateful for the opportunity. Congratulations as well to all the presenters, the presenters in today's session. Extraordinary work and engaging presentations for a very important conversation. So thank you all so much. I will try to be brief in my comments. I'm going to set my timer here so that I stay on track. And let's dig in and talk a little bit about the CUGH capacity strengthening platform. So I'll do my best just to give you a very, very brief overview of what this is, and then spend the majority of my time today really focusing on how to engage. You'll see the code on most of the slides today, so please engage and go ahead and scan and try to make your way onto the platform. We're going to really encourage that over the course of the conference. So this is a global matchmaking web platform, thinkmatch.com, for global health equity, facilitating equitable institutional partnerships and mentorship to strengthen health workforce training capacity. This is the, sorry, I'm getting a couple things out of my way here. All right, this is the URL where you can go to log into this platform. And that is aimed at strengthening training capacity globally by connecting trainers with training needs. All right, this is some of the team that has been working on this over the past several years. And we were originally funded through the Tom Hall Education Committee Small Global Health Education Grant in 2017 for phase 1. Phase 2 has been funded by the U.S. Civilian Research and Development Foundation. So we're really grateful for the funding, and we continue to seek additional funding to continue to move this project forward. So I won't go into detail on the next couple slides, but healthcare workforce shortage is critical, and this this workforce is essential to equitable access, universal health coverage goals, and sustainable development goals. And there is a global shortage of 18 million health workers by the year 2030, and this particularly affects the World Health Organization African region, with disparities between and uneven distribution within between countries. So looking there at 0.25 health workers per thousand in Niger and 9.15 in Seychelles. So the platform is focused on partnerships, training programs, and mentorship. So there are opportunities to connect among those and within those three main categories. Individuals and institutions can connect and share training resources to strengthen in clinical and research capacity in low resource settings. This addresses a couple major challenges, particularly the lack of qualified trainers and mentors, as well as the challenge of connecting existing expertise in established training programs. So let's dig into this global matchmaking web platform and see how it works and see how we can engage. So there are multiple steps, and I'll take you through these steps. Principally, we're going to register, then we'll create postings, and these can be for training needs and expertise, or established trainings, or mentoring opportunities. The first one being primarily to facilitate the linkages between institutions or individuals to institutions to establish these partnerships that we're discussing. Once postings are created, then you can search in order to find new partners or to find existing training programs that are available for individuals to engage, to enroll, and or find mentors and mentees. And then within the platform, you can also connect through direct messaging to other individuals and institutions, or to existing enrollment-based training programs, or to individuals. And then we can all strengthen capacity together. So let's look first at the registration process. This is how you'll engage with the platform. So when you go to the CUGH capacitybuilding.org URL, or scan the code, you can click the sign up button, and that will take you to this page. There will be a minimum amount of information that you'll need to enter, including your institution name, and then it will create for you a dashboard. And this is the profile page, and you can further improve the information that's available on your profile page by uploading some photos. And then also you can edit your profile here. When you edit your profile, you'll be asked to provide some more additional institutional information through that link, just to provide more information to those who may want to engage with you on the platform. After you've created your login, then you can create postings, and we encourage everyone to do so. So you can create postings through the dashboard and then the create posting link. And once you do that, then you'll be able to enter a title for your posting, and you'll have several opportunities to categorize your posting. So you can categorize your posting into as a partnership, in which case you can choose among this top one here of general posting or implementation science posting. So these are two main areas that our platform currently focuses on. And so we would encourage engagement across those. And you can also then categorize your posting as a training program, or as a mentoring opportunity, or as a partnership opportunity. And then you can also stipulate whether or not you are seeking training expertise, or providing training expertise, or if you're seeking training. And so this would be the way that you could potentially fill out these areas with a posting title at the top, categorization as follows, and then you would have the opportunity to provide additional information around that particular posting. For the partnerships, training program looks very similar. You would just select training program for example, implementation science seeking training program, if you want to post a training program, and then you would be provided the opportunity of providing some additional context about your training program to provide more detailed information. So please take the time to go through and select and answer the ones that apply to your particular training program if you're wanting to post it on the site. That provides a lot more detailed information. And then you can provide a brief description, additional information, and a URL link to the relevant website for your training opportunity. And then you can submit that information. If you're wanting to provide a mentorship opportunity, very similar here. You're just going to provide the seeking mentoring, and then you can stipulate whether you're seeking a mentee or seeking a mentor, and take it through a very similar focus. And then once the postings are created, or if you don't want to create a posting, you can go directly to searching the existing postings. And this can be done through the search postings link on the left, or on the dashboard. You'll have two opportunities to search the general postings or to search the implementation science postings in particular. And this is what the search page looks like. Please note that you can search among keywords or among other filters. If you're searching keyword, then you simply just type in what keyword you're wanting to search for, and that automatically filters based on those keywords any postings that are relevant to those keywords. If you want to search particularly by other filters, then you can filter, for example, by implementation science and then seeking training programs, and then it will automatically filter based on the programs that are available there. So that's the way you can seek and identify those programs. You can click on those programs and it'll take you to a program page that has been created by the owner of that particular posting, and it provides a lot of good information for you, as well as the contextual information that's off to this side of the screen, to the right side of the screen. And so this is very detailed information and gives you an understanding, is this something that I might be looking for? At the bottom of the posting, you'll see an opportunity to connect to the person who owns that particular posting. So you can click on the connect or the save button, as you can see here. If you can click on those, then it will send a request to that individual to connect, and you can potentially save that listing to your own saved listing postings, and I'll show you that in just a bit. If you want to directly message the individual who has created a particular posting, then you can click on their name and it takes you to their own profile. You can go to the timeline of that individual, and that's where you can conduct a conversation with an individual. On their timeline, you can send a message, write something. And I'll show you how that works in just a little bit as well. Then once you have gone through several postings and saved them, you can identify them from the main page in the saved postings area. And you can take a look at that, and then you can click on that and it'll take you to your own saved postings. So those are the ones that you have saved. You can unsave them by unhearting them at any point, but that's a way that you can kind of peruse and find ones that may be interesting. You can come back to them at any time and take a closer look. All right, so let's talk about connecting. And you can access the connections through the link at the left. And then through an individual's timeline as well. You can, as I mentioned, send messages directly to individuals. So if you click on timeline, you can click to share what's on your mind. If you click on that, then it takes you to create a post. Then you have the opportunity to say, who would you like this message to go to? It can go to public, where anybody who visits your page will see this, or all members, just those on the site, or to your direct connections, or to something that's visible only to you or the person that you're directly messaging, if that be the case. So if you choose public, then you can create a post, and then you can also like or comment existing posts by other people. And you can see how to do this here, and then just post that comment. If you've clicked on someone's direct name, again, you can go to their timeline and write something to that person. And then make sure you select the only me, which is a direct post to that individual, and it won't be public. And that way you can conduct a conversation about whether or not you want to create a partnership or create a mentoring relationship on the site without revealing your personal contact information. If you choose to reveal your personal contact information through the site, then of course you can do that through these direct messages, provide your email address to that individual, and then you can take your conversation offline and advance the partnership or advance the mentoring relationship. But this allows you to keep your information secure until the moment that you choose to reveal that information to the individual of your choosing. And then step 5, of course, is let's strengthen capacity together. And so you can, again, engage in your saved postings, and then visit the messages portal here, where you can see all of the messages that pertain to you, and continue those conversations and advance those relationships and develop those partnerships, mentoring relationships, and join those existing training programs. So please contact us by clicking on the contact button at the top. And then you'll have the opportunity to provide us, ask us any questions through the site, and provide us feedback as well at any point. So this platform aims to address certain global health partnership principles, such as equitable matchmaking, to make sure that these partnership opportunities are not ad hoc, but actually function through a way of engaging and ensuring that partners have the opportunity to transparently list their own training capacity priorities, so that, for example, high resource institutions or those with existing grants are not driving the priorities of the training capacity needs of institutions. But this platform will create the opportunity for every institution to list their highest priority training capacity priorities, so that we can all engage through a transparent and most efficient manner. It also provides the opportunity for strong contextual understanding between the partners and facilitates equity, reciprocity, bidirectionality, social justice, and humility within these partnerships. It also provides the opportunity for local priorities to drive the external focus and responsible distribution of partnership benefits. It facilitates local partnerships as well, again, for efficiency, and then encourages long-term partnerships, which builds mutual understanding, institutional memory, and effective synergistic relationships over time. So this is where you can find the capacity strengthening platform. Here are some references from today's discussion. And thank you all so very much for the opportunity.
Thank you so much, Andrew. And I mean, what a fantastic platform. I think it's just a great way to amplify both the requests for certain training and needs, and as well as for high income countries or well-resourced universities who have something on offer to be able to sort of advertise. And as you say, the matchmaking comes from sort of both sides coming to the table and wanting to partner. So I think that's wonderful. Would you be able to share that link, at least the website link, in the chat? I know you've had it up and plenty of opportunity for people to scan, but just in case they didn't have their phones or want to look it up another time and stash that away, perhaps that would be good. Okay, colleagues, we now have a bit of time to engage in some discussion. I did want to open with a question to David Muganzi around student involvement in global health. I was just wondering, are there international platforms for students to connect around global health? Because we find in global surgery that the students are really the energy and the driving force for almost the entire movement. There's a group called Incision, which connects global students interested in global surgery from around the world, and they host their own conferences and have really been very, very active in kind of the whole global surgery movement. So I was wondering, either David or Elsie if there's a global health student movement. And then the next question I'll address to Ian Cooper, but I think one of the challenges in low and middle income countries is what is global health to trainees? So like students, medical students, for example, nursing students, and often in the curriculum, there isn't that term ever used. And here at Stellenbosch, we've moved on to a new medical school curriculum. And I think Bebe Bekele has left the call, but at the University of Global Health Equity, they also have, well, they're a new university, but a medical school curriculum that focuses on global health. So I'm wondering if part of the problem isn't just the lack of awareness of what that term means. Maybe I'll start with David. I think we may need to just unmute folks. And Elsie, I'm also going to ask to unmute you, and then I'll unmute Ian. And then if anyone else wants to make comments around the term global health for trainees and the ability for students to interact, just raise your hand. David?
Yes, thank you very much. So to the first question, whether there is a platform specifically for global health like there is for incision, the straight out answer is no, but there are communities which are working around global health as one of their major issues. For example, the International Federation of Medical Students, IFMSA, which is one of the oldest. I think even the Students Network Organization, SNO, there is a component of global health there, even AfreHealth itself. So there isn't one that is focusing on only global health, but there are a number of them that have global health as part of their mission or vision and part of their activities. Then to the definition of global health for a health professional student, from my perspective, I think it is mostly getting to be part of activities that have the global health in their agenda, because there is not much in the traditional curriculum that is talking about global health. So it's mostly out of class experiences. Yeah, that's what I think.
Thank you, David. Elsie, any comments about that definition of global health or anything else around what we've been discussing?
Thank you, Catherine. I think I have the same answer as David on the global student movement for global health. And those ones he has mentioned are really active, and maybe we could find some way of connecting the AfreHealth community with the student network organization. And I know already AfreHealth community has connected with the CUGH tag and see some way of assisting those student community to form maybe a global health community. The issue of global health definition for students, I think, is really exposure. And I like what has been added as saying maybe we should say global health equity. But what I observed during the Medical Education Partnership Initiative is that what we are really talking about is the practice in many institutions in Africa, but it has not been defined as a global health as such. So if you just search for global health in their curriculum, in the way they do things, you may not find it. But if you scrutinize what they're doing, for example, through the community-based education and service programs in most of the communities, in most of the schools, they address global health. And also like a Stellenbosch through the rural school, they also do. So it's a matter of really scrutinizing what they do if you want to find it. In the African region is being done, but it's not being called global health as such. I don't know how we can get around that so that we recognize that that what they are doing is really global health also, although it's called different terms in the different places. Over to you, Catherine.
Thank you, Elsie. And Ian, at Stellenbosch in the new curriculum, is there more of a emphasis on what is global health?
I'm not sure if there is, to be honest. I mean, I agree with what Elsie said around the focus on equity rather than necessarily the term global health. And I think one of the things that creates a bit of a tension, you know, around global health is that whole thing of training people for local context and you know, not to be seen to be as has been the past so often in South Africa, encouraging people to be prepared to practice in, you know, in other countries and actually not in our own backyard. So, I mean, I think if we are linking it with equity and having that as a key focus, which is certainly in our renewed curriculum, is an important aspect of that. I think that will address it.
Thank you. And then Judy Cagnola, you're from a university called the University of Global Health Equity. With your nursing students, is there a specific emphasis on global health and what that is, or an emphasis more on sort of equity in health? Judy, are you there? Okay, looks like maybe she's not with us. Okay, and then maybe the next question I have is for Andrew. In terms of the platform, it sounds wonderful in principle. Yeah, Elsie, I did try to invite her to unmute, but she didn't. For the capacity building platform, it sounds amazing in principle. I was just wondering if you could talk about the ways to amplify the program, or perhaps you already have thousands of users. But if not, if it's still kind of being advertised, you know, what do you think would be some facilitators for its success? Oh, and I maybe need to unmute you. Sorry, hang on one second. Apologies there.
No worries.
Okay.
Thank you so much. Yeah, absolutely. So over the last year, 2022 was when we moved forward with this so-called phase 2, which is the current version of the platform that you see online currently. This was launched last fall, and then there's been a period of kind of some adjustments and refinements. And so we are now encouraging as many people as possible to engage with the platform. We will be initiating concurrently and soon after the conference a series of posts that will go out to newsletters as well as on the site itself to engage people who are currently on the site. To encourage and facilitate their further engagement. We'll be highlighting certain postings and such. And so we're very hopeful to really move this forward. In the course of the last, let's say, 5 or 6 months, we've already almost doubled the number of people that was signed up, registered for the phase 1 of the platform. And we anticipate that during the conference we'll considerably increase those numbers. So we're really hopeful as many people as engaged as possible. Obviously, that brings a significant value to the site. So please do get on, pass this along to everyone and all. We will continue to make gradual improvements to the site as well. So we very much welcome feedback. Yeah, thank you so much. Hopefully that's answered your question.
Yeah, no, that's great. Teresia had a question. I'll read it in the chat. Is it mandatory to be a member of an institution to use that CUGH capacity building platform? For those people that might not be part of a CUGH institution, can they use it? Sorry, I've now unmuted you again. Oh.
There we go.
Okay.
Yeah, so currently the site is open, so anyone can engage with the site. We do ask for your institutional membership to catalog that along with your registration. So currently it's open. We may have to place restrictions on the site in the future depending on the membership numbers and that sort of thing. And we have background administrative capacity to be able to do that. For the moment, it's open to all. It will always remain open to all. Let me clarify that in terms of the ability to search and engage. But right now the restrictions are fewer in terms of immediately accessing the site. I think I've stated that properly.
Yeah, and I mean, I think that, you know, to take a step back, one of the overarching questions here was how can CUGH work with AfreHealth to strengthen global health capacity in the region? And I think that this platform could be a very concrete way to do so, as you called it, the matchmaking website. And I think that, you know, in this world now, Quentin pointed out that people are getting much more to virtual meetings of one another, especially the initial matchmaking meeting can happen online. People are more comfortable with that. And I think that this really just allows many more people to meet in a virtual space that, you know, may not have had the opportunity to go to a conference and find a high income colleague somewhere, for example, to partner with. You know, specifically in surgery, there are often places looking for sort of anastomosis and surgical, like bowel anastomosis courses or basic suturing courses for their trainees, whether they be medical students or their surgical program. And there may be high income countries, institutions out there who are willing to provide that and are looking for an outlet for their students and trainees and faculty to engage concretely in a project. So I think this could be really great. There is another question in the chat, and I see that Judy has joined. Sorry, Judy, the question specifically was that maybe in some places here on this continent that students, so nursing students, medical students, don't understand the definition of global health. And so trying to get them more involved in global health training or capacity building, they may not really know what that means. And since you come from a university that's relatively new and is called University of Global Health Equity, I was just wondering with your nursing students, if there is a conscious effort to teach what global health or global health equity means at your institution that might not be at ones who have more traditional teaching. Thanks, Judy. Oh, let me unmute you again.
Yes, there is, Catherine. It's a very interesting discussion we are having. Yeah, at UGHE, we do intentionally teach global health, and this cuts across every program we have. And I guess it's sort of our niche as we position ourselves. Of course, from my own perspective and just my own personal viewpoint, the definition of global health is tricky, not, I mean, global, well, universally accepted. So that can be, you know, we can be tasked on that. But I want to say UGH's version of global health is taught across all the programs that we have. It's part of our curricula. It's part of the cutting across subjects that we teach. And then I think intentionally just away from theory is really looking at inclusion and inclusivity and the whole issue of equity. So people who can't pay at UGHE are not stopped from you know, going to medical school or nursing school, because we are intentionally saying that some of these things that have been barriers in the past towards equity, towards someone who wants to go to medical school has passed but cannot get in because they can't afford it, are now intentionally being broken down. We intentionally take women because that has been traditionally, again, you're a woman, there are challenges you face in Africa, particularly that stop you from reaching XYZ. So UGHE then says we'll take, you know, intentionally more women, more sort of the marginalized populations. And so I hope that answers you, but those are some of the things that we are doing. When students get into the medical or nursing school, we work in the community right from year one, so that people are seeing what is this inequity. It's not just from on a textbook in a paper or a picture, but you're actually walking the talk. Thank you.
Thank you. Yes, that's, I think that's so important to change that narrative. I see that Dr. Elsie has her hand up, and I hopefully I've unmuted you there. And then after you, I'm going to ask Jude to verbalize his question that he put in the chat. But over to you, Elsie.
Okay, thank you very much. Just thinking about capacity building through the years of MEPI, NEPI, and AfreHealth, I've learned not to overlook the immense capacity within the African region itself, and how untapped in most cases it is. So I think this is up to us also in the South to realize how much capacity we have and how we can share it out. And through AfreHealth, we are really trying to ensure that we really get that capacity and make sure that it is shared across the region. And of course, between south to south, and then we add on north, then it really makes it even the capacity, of course, expands. And I was just thinking that with Andrew, we have not really discussed this. I was just wondering how we can make sure that people don't think it's just north-south, that we can also see south-south, so that that is not buried even when we are looking at that platform. Thank you. Over to you.
Okay, yeah, and I think that is so important. I mean, even within, in the Southern African region, there have been examples of collaborations between universities within Africa. We're currently involved in a grant with a UK organization who's also the funder, but there's universities in Rwanda, universities in Ghana, and universities in South Africa. And we are now just helping one another train. And so the UK partners are not eliminated, but they actually don't need to make in-country visits because, one of us sort of tries a bit of the project and it has failures and successes, and then we go to the other countries to kind of teach what we've been doing. And so that for us has been quite sort of empowering because we've shown that we can sort of help ourselves in that setting. I'm going to read Jude's comment because he's unable to unmute, but he wrote, the Global Health Capacity Platform would certainly need global health influencers and institutional focal points to drive the content and demand. I was involved in a similar website for health research that struggled, and those are some of the lessons learned. The current format is a little complex with regard to just emailing. Andrew, I don't know if you want to comment back on that.
There we go. Okay. Yeah, absolutely. Thank you so much. Yeah, I agree. There's going to need to be a plethora of modalities for quote unquote spreading the word and marketing this platform, getting it out there. We are going to experience some growing pains, no question about it. We already have to this point. This is, phase 2. So we've had a significant learning opportunity over the past several years, and we're going to learn a lot more. There is complexity, agreed, in the way that this platform is structured. It's trying to hit a middle ground between a highly complex database structure and a structure that really facilitates very simple engagement. But that sort of complexity or categorization of postings really facilitates the filtering process and the opportunity to search across postings and categorize them and identify them very readily so that individuals can find what is very specific to their own needs. And I'll take the opportunity as well to highlight what Elsie was stating, and I really appreciate her bringing that up as she to highlight one of the main pieces of this platform is really to facilitate engagement of institutions, irrespective of locality and resources. So really this fostering of local partnerships is one of the main drivers for developing this this platform. And so the hope that this will facilitate more South-to-South partnership engagements. Obviously, that's a lot of efficiency in identifying the resources locally, and creating those sorts of partnerships builds significantly more capacity in a much more efficient and impactful manner. So absolutely. So please do engage in that way. It's a very, very important point.
Thank you. Thank you both. I see that Abebe Bekele is on it. I did want to ask a question about training specialists versus non-specialists. So in a partnership or in a college like COSEXA, training surgeons in 14 different countries, much of the surgical care on the continent is delivered by non-specialists. Do you train non-specialist surgeons as well? And will there ever be the opportunity to reach out and work with family physicians or even clinical officers or clinical associates within the surgical field? And Abebe, I think I need to ask you to unmute if you're available to respond.
Yes, thank you, Catherine. Yes, at the moment, COSEXA is not training non-physician surgeons. The stand we have is the task shifting and task sharing is context dependent. There are some countries, 47 countries in Africa, that use non-physician providers extensively, all of them in anesthesia, I believe, but about 47 in surgery and obstetric care. It should be context. If countries, depending on the need they have, want to go to that direction, we don't oppose. If there are some countries who have are almost there, who are reaching the critical number of providers in their countries, if they prefer to stick to training specialists, we don't stand on the way. That is the stand we have. But unfortunately, at this time, we don't train non-physician surgical providers. Another model I think we can talk about is the majority of cesarean sections and basic surgeries provided by physicians who are not surgeons in the form of task sharing. These are general practitioners. The way it is that these doctors graduate, they are assigned to a district hospital and they learn the job, the work on the job. They learn doing cesarean sections on the job. They do appendectomies on the job. What we're trying to do at UGHE, where the institution I'm now in, is we're trying to train the medical students while they are under us to do cesarean sections, appendectomies, and closed manipulation of fractures and wound care, including the lumps and bumps of surgery. That is how we wanted to define task sharing us in Rwanda at UGHE. So that's one model that can also work. But I don't think there is a universal solution that addresses all countries at the same time.
Yeah, and I think that's a great point to try and target the medical students. I think in South Africa, we have similar desires for our interns, for example, to do a certain minimum number of cesarean sections. We don't really have that specifically for medical students, although our medical students get a lot of hands-on, but it's a bit hit or miss. And by the time they finish their 2-year internship, they're supposed to be able to do cesarean sections independently. And I think it's been quite well accepted about the cesarean sections at district hospitals, but some of the other procedures like fracture reduction, to do simple wound debridements, abscess drainages, maybe not so much. And so perhaps to get there, but as you say, it's probably very context specific. So yeah. Elsie, do you want to make a comment about the fact that you graduate with medicine and surgery? Might have to unmute you again, just a second.
Yes, thank you. In most of the sub-Saharan countries, especially those ones which were under MEPI that we visited, they qualify with both medicine and surgery, but of course limited general surgery like cesarean section, INDs, those are done by most of the graduates out of most of the schools. And as Abebe said, some are even going to other like clinical officers can do some of the surgeries. But I think it's contextualized, as you said. And as time goes on and more surgeons are trained under such an umbrella as COSEXA, some of these tax shifting may actually no longer be necessary. But of course, it will take time. But for the time being, what COSEXA is doing is really commendable, because the universities could not handle this training. And so for increasing the numbers, this is very, 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 very important. But as the numbers increase, the surgery that can be done by others and general doctors, of course, is welcome, with good training, of course, and monitoring and evaluation. Thanks, over to you.
Thanks. And then maybe one last follow-up question for Abebe is that how did you get the countries to recognize the COSEXA exams as the exams that they, for their national medical councils, would accept? Because, you know, if there's others on the call, there's anesthetists on the call, pathologists, and, you know, if they had been thinking of a similar program because of the shortage in their countries, you know, how did you overcome that? Because you can do all this training and then you can't practice in your own country.
Yeah, a very interesting question, Kat. COSEXA was established in 1999. We will be celebrating our 25th anniversary next year. It has been a difficult journey. It needed a lot of advocacy, championing work from senior COSEXA fellows in each of the 14 countries, particularly the more established countries. Those countries with an established university-based training, like Tanzania, Uganda, Kenya, Ethiopia, they were very difficult to convince. The newly joining countries who are already convinced on the importance of COSEXA, it was easy. But having it accredited across the 14 countries needed about 20 years. It was not easy. A lot of convincing the ministries, a lot of convincing of the existing practitioners, the senior faculty. The key is you should not be seen as a competition. You should be seen as complementing one another. Unfortunately, at the beginning of COSEXA, that was the prevailing understanding. It was like COSEXA was competing with the universities, and we unfortunately created a lot of enemies among the professionals. But time solved a lot of things. And countries like Kenya are now expanding the COSEXA program significantly. Kenya, I think, already has about 22 hospitals accredited. Ethiopia has about 14, 15, Zambia, Zimbabwe. They are utilizing the program significantly. So it has been a difficult journey. Now, the other colleges are now under EXA are coming up. The OBGYN college, the anesthesia college, the ophthalmology college are slowly coming up. They will face the same challenges, but hopefully will not be that difficult like ours.
Thank you. I see that Georgina has a comment, and then perhaps after that, I'll ask Elsie if she wants to wrap up for us because we're out of time. Georgina?
Thank you, Catherine. I had a question for Abebe earlier after his presentation, but I noted I put it in the chat box and that was not asked, so I just want to ask that. I want to find out how COSEXA is working together with other regional postgraduate colleges. In West Africa, we have the West Africa College of Surgeons. And so I want to know how they are working together with them to improve on the quality of human resources on the continent, especially in the area of surgery. And then also the nursing colleges as well, because know that I'm talking from the AfreHealth point of view in the interprofessional and collaborative practice. So I want to know how his college is doing that.
Thanks, Georgina. So
Yeah.
great to hear from you. There are three big colleges in Africa: the West African, CUGH, and the Colleges of Medicine of South Africa. Since 2008, these three colleges have what we call the Pan-African Association of Surgeons Association. So these three colleges have been working together for quite some time. We exchange external examiners, we attend each other's AGMs and exams. We sometimes share written exams, curricula. We do educational programs together. At the moment, we are trying to renew the partnership. We are taking it to one step further to create a formal association, formal partnership, registered with a secretariat, with some funding attached to it. We are all three are convinced that one cannot survive without the other. It's such a small world, and there is a lot of resources we can share amongst us. Every year we receive 2 appointed external examiners from both colleges. I've served as an examiner for the South African College twice, and once for WACS, and several volunteers that come and join us from these colleges. And there is a lot of student exchange. What's also interesting is that CUGH also has presence in some of the WACS countries like Cameroon, like Gabon. We have hospitals we're training in Cameroon. The expertise of the South African College has been very helpful to CUGH and WACS in terms of quality of examination, psychometric analysis of examination, and others. So in short, we work very closely together, and we believe it should be stronger.
Thank you very much. I think in the interest of time, we need to wrap up, but this has just been an amazing discussion. I'll see if Dr. Elsie wants to have the last word, but just to say that we've had an amazing panel of 6 different speakers, starting from Elsie, giving us a background of the CUGH AfreHealth working group, and to remind us all about the AfreHealth conference coming up in Maputo in August. We heard from Professor Omasa about about mutual global health partnerships and how the high-income countries can learn a lot from the global south, and the need to train our leaders to be able to manage and predict the healthcare workforce and the programs that they would need. We heard from Abebe Bekele about CUGH, we were just talking about David Muganzi, about how students can get involved, from Quentin Eichbaum about the survey we did globally during the pandemic, about how maybe the definition and travel and global health may change. And then finally from Andrew Dykins about this amazing CUGH capacity building platform that I hope we all can use. But over to you, Elsie, just for the final words.
Yeah, thank you very much, Catherine. I'd like to thank CUGH and AfreHealth for getting us together through the working group. Thank you very much for attending. Thank you all presenters for your wonderful presentations and discussions. I'd also like to thank all the participants for your questions and discussions. It has really been a very interesting afternoon or evening or morning, depending on where you are. So we will be continuing with the SCWG work. So the fact that you have registered for this meeting, we assume that you are interested, and we will contact you and see how we can continue to work together. Going forward with the SCWG, we really want to see how we can do capacity building. And that's why we invited Andrew to share with us that about that capacity building platform, and we see how we can use it both for on the side of CUGH and AfreHealth, and increase collaboration and partnerships. So if you want to go fast, you go alone. If you want to go far, you go together. So I believe that we want to go far, and that's why we are together. And I would like to wish you all pleasant morning or evening or afternoon. And please continue attending the other satellites. There are many interesting satellites, and those who will be at CUGH, we shall continue with the discussions. Thank you very much, Catherine, for moderating this. It has really been wonderful. And bye.
Thank you, everyone. Bye.